Good. I'll be speaking to you about treating the opioid client. My name is Deborah Lemet, and this is a PowerPoint for the Addictions Care Center of Albany. Thank you. I do not claim to be a physician, and I'm not dispensing medical advice. I'm synthesizing available information from literature for the purpose of teaching the behavioral health professional about treating the opioid client. The learning objectives today are going to be split in two because we're going to be doing a sequence on Thursday, so we will not cover all of them today. So we're going to learn an understanding of what opioid addiction is, ASAM standards of care for physicians, what are the recommended medical interventions, what are the recommended best practices for counselors, what are the risk factors of being addicted to opioids, what are interventions, and what are some community engagement and awareness techniques and practices. So what's an opiate and an opioid? When the DSM-5 came out, we had the term opioid instead of opiate. And that was because there was a variety of synthesized opiates being manufactured by the medical community and used illegally. Opiates are a narcotic analgesic derived from an opium poppy in the natural state or form. We get the derivative of heroin from the opiate or poppy, but heroin is classified as an opioid. Opioids are narcotic analgesics that are at least part synthetic and not found in nature. Opioids are a class of drugs either derived from or chemically similar to compounds found in opium poppies. Opioids include legal prescription painkillers such as oxycodone, OxyContin, hydrocodone, Vicodin, morphine, codeine, fentanyl, and others. The picture here we see is this is the heroin, and this is the morphine component. Opioid addiction. The American Society of Medicine describes addiction as a primary chronic disease of brain, reward, motivation, memory, and related circuitry. Opioid use disorder criteria is problematic pattern of opioid use leading to clinically significant impairment or distress as manifested by at least two of the following criteria in a 12-month period. Opiates are taken in larger amounts over a longer period than was intended. There is a persistent desire or an unsuccessful efforts to cut down or control opioid use. A great deal of time is spent in activities necessary to obtain the opioid, the use of the opioid, or recover from its effects. Craving or a strong desire or an urge to use opioids. Recurrent opioid use resulting in a failure to fulfill major role obligations at work, school, or home. Continued opioid use despite having persistent or recurrent social or interpersonal problems caused or exacerbated by the effects of opioid. Important social, occupational, or recreational activities are given up or reduced because of opioid use. Recurrent opioid use in situations where it's physically hazardous, such as driving a car or operating machinery. Continued opioid use despite the knowledge of having persistent or recurrent physical or physiological problems that is likely to have been caused or exacerbated by the use of the substance. Tolerance increases. It's marked by the following: a need for increased amounts of opioids to achieve intoxication or the desired effect, or B, a marked diminished effect with continued use of the same amount of an opioid. This criterion is considered to be met for those who are taking opioids solely under appropriate medical supervision. Withdrawal as manifested by the following: opioid withdrawal syndrome. Opioids are closely related and taken to avoid or relieve withdrawal symptoms. Opioid use disorder is chronic, progressive, and fatal. In the United States, more than 1,600,000 have an opioid overdose. In 2013, the health cost for treating opioid use was more than $78 billion. In 2017, there were more than 72,000 deaths from fentanyl. In 2017, there were almost 30,000 deaths from synthetic opioids. In 2017, there were over 15,000 deaths from heroin. In 2016, there were almost 9,000 opioid overdoses. And in 2016, there was 1,800 opioid overdoses just in Albany County in New York State. So there are some specifiers with opioid use disorder. This criterion is considered to be met if individuals taking opioids solely under the use of a physician. So sometimes we have physicians who are prescribing opioids, and we have to put this specifier in the criterion. And what that means is to let the treatment planning committee know that this patient was indeed taking opioids under the direction of a physician. In sustained remission. So sometimes the full criterion for opioid use disorder was previously met, but none of the criteria for opioid use disorder have been met in any time during a period of 12 months or longer. So in sustained remission is also a specifier. The way you write a specifier is after the diagnosis. So you would put the diagnosis down, then you would write a comma, and you would write in sustained remission under medical supervision. These are specifiers. Another specifier is in a controlled environment. If the individual uses an environment where access to opioids is restricted, such as in a clinic or care center. In early remission, after full criteria for opioid use disorder were previously met, but none of the criteria for opioid use disorder have been met for at least 3 months. 3 months is considered early remission. On maintenance therapy, this is when someone is taking opiates such as methadone or Suboxone. Coding. Coding is based on the current severity. For the ICD-10 codes, the opioid intoxication, withdrawal, or another opioid use-induced mental disorder is also present. Do not use the codes below if any of these is indicated. So 305.5, which is opioid use disorder, mild, is now F11.10. And it's the presence of 2 or 3 symptoms for opioid use disorder. 304.0 is opioid use disorder moderate, and it's F1120. It's the presence of 4 to 5 symptoms for opioid use disorder. And 304.0 in the DSM, or F1120, is severe. It's the presence of 6 or more symptoms of opioid use disorder. And again, if you were writing this, you would put a comma next to that, and then you would put your specifier in, such as in sustained remission and early remission. The most common medical condition associated with opioid use disorder are viral and bacterial infections such as HIV, hepatitis C virus, particularly among users of opioids by injection. Opioid use disorder is often associated with other substance use disorders, especially those involving tobacco, alcohol, cannabis, stimulants, and benzodiazepines, which are often taken to reduce symptoms of opioid withdrawal or craving for opioids, or to enhance the effects of administered opioids. Individuals with opioid use disorder are at risk for the development of mild to moderate depression, that meets symptomatic and duration criteria for persistent depressive disorder, dysthymia, or in some cases, major depressive disorder. Periods of depression are especially common during chronic intoxication or association with physical or psychosocial stressors related to opioid use disorder. Insomnia is also commonplace. Antisocial personality is more common in individuals with opioid use disorder than in the general population. That was comes from Compton 2005 in a study of comorbidities of opioid use disorder. Post-traumatic stress disorder is also seen in frequency, and that comes from a study from Price in 2004. And the post-traumatic stress comes from basically the trauma associated with using opiates. Some of the people, places, and things are traumatic. Some of the incarcerations, some of the arrests, some of the places that people use opiates, what they do to procure opioids. A history of conduct disorder in childhood or adolescence has been identified as a significant risk factor for substance-related disorders, especially opioid use disorders. These are all studies from SAMHSA. An addiction specialist physician. This is a physician that specializes in prescribing Suboxone, methadone, Sublocade to patients with opioid use disorders. They have to have specialized training before they can do this, and they're called addiction specialist physicians. As counselors, it's important for us to know how an addiction specialist physician works. Addiction specialist physicians include addiction medicine physicians and addiction psychiatrists who either hold a board certification in addiction medicine from the American Board of Addiction Medicine, ASAM. And the subsidy board is the Addiction Psychiatry Board, which is called ABPM. A subspecialty board certification in addiction medicine is also from the American Osteopathic Association, AOA, and a certification in addiction medicine from the ASAM, from the Addiction Society of Medicine. So you can have specialties and subspecialties in addiction medicine. They must keep abreast of the changes in the laws regarding illegal substances, how those substances are prescribed, how to prescribe controlled substances, and the criminalization of behaviors associated with substance use. Clinical alternatives to criminal prosecution and incarceration, and interfaces between the healthcare system and the criminal justice system, including community corrections. They must have an understanding of complying with all applicable federal, state, and local regulations regarding to patient confidentiality. They must obtain informed consent, ensuring that patients understand the extent and limits of their privacy protection. Addiction specialist physicians should maintain their licensure to practice medicine under their certification as addiction specialists. This includes remaining current regarding clinical advances, participating in regular self-assessment, and demonstrating that through participation in a plan of lifelong learning is a practice improvement. And they actively engage in the maintenance of their specialized clinical knowledge and competencies, commensurate with a complex and ever-changing field of addiction medicine. The addiction specialist should be able to deal with substance use disorders as well as concurrent problems that exacerbate or arise from the patient's addiction. The addiction specialist physician should have a good understanding of local cultures and subcultures and what local resources are available to support the patient's recovery. Ultimately, the patient's care should be orientated towards overall functioning and well-being while mitigating standards of risk. And they need to address their clinical administrative roles and not simply what knowledge of skills or competencies they possess. There are specialized standards of care for the addiction specialist physician to understand. They must understand assessment and what assessment includes. Assessment of a patient with a process and how to process their substance use disorder. And it's important to know that it does not necessarily to be conducted at the initial visit. But in certain practice situations, it can be ongoing. But in emergency situations, an assessment may be brief. They would use an expert assessment. And some of you have been trained in expert. Focused assessments may be appropriate, but a comprehensive treatment of addiction requires a comprehensive assessment. Now, that's why we work hand in hand with the addiction specialists, because they're not going to sit down and do the psychosocial, but they're going to rely on our knowledge of doing a psychosocial and putting in detail that pertinent information. So when they prescribe the Suboxone, they're prescribing the right amount of medication for that patient. A complete assessment is a critical aspect of patient engagement and treatment planning and should be conducted at the initial phase of treatment. The addiction specialist physician is the professional most able to determine the appropriateness of the medications used for the addiction and the data in calculations and what is needed for that particular patient. And the indications for pharmacological therapy and various psychosocial therapies are kept in mind when we're doing the assessment. So we need to weed out for that physician all of the pertinent details in our psychosocial assessment. Now, I've been in the field for over 20 years, and I've had a variety of psychosocial assessments from the places I've worked for. The longest one was probably 6 pages long, and it was very detailed, and that was prior to having Suboxone maintenance. And I didn't understand why it had to be so detailed as a young clinician. Now I know. It's because our data that we collect helps the medical team put together the right medications for that patient. So a standard comprehensive assessment includes a physical exam, a mental status exam, a medical and psychiatric history, a substance treatment disorder history, allergies and medical comorbidities, patient motivational levels, a detailed past and present substance use history, withdrawal potential, other addictive behaviors such as exercise, gambling, pornography, history of pharmacotherapies, what the recovery environment is like, what could be barriers to treatment, what family medical, psychiatric, and substance abuse histories are present, what is the social history of the patient, what consultations with other appropriate sources of information, what is there that we can use for collaborative care contacts, a summary of the patient's readiness to engage in treatment, and potential to use addictive substances in the future, and of course our diagnostic formulation. This all helps the addiction specialists in their job in prescribing medications for our clients. Standard 2 is understanding withdrawal management. The addiction specialist physician assesses to the extent of which withdrawal management is needed for specific classes of drugs. They assess the need for withdrawal management and appropriate treatment environment for the patient's severity and symptomology. The addiction specialist uses validated objective measurements of intoxication and withdrawal with validated instruments. It's important that we know what instruments they use and how to read those instruments as well. They pay attention to co-occurring psychiatric complications during withdrawal management with a person with a substance use disorder. In other words, I have had doctors that I've worked with in methadone clinics and Suboxone clinics say to me, well, I'm not going to prescribe for this patient until they engage with a psychiatrist. And the reason they're saying it is because they're seeing that this patient may have a diagnosis of a personality disorder, which could complicate their medication regimen. Or they could have a criminal history and they need a mental health counselor to meet with them prior to engaging. They document medical decision-making in treatment planning and the level of care consideration for a patient undergoing withdrawal management. So that is part of the treatment plan, that you have a doctor that's willing to engage in the treatment planning process. They're not going to document it. We're going to be the scribes. We're going to be the ones that document what they say, but we need to document their medical decision-making in our treatment planning process and in our note-taking. Standard 3, treatment planning. The addiction specialist integrates and coordinates the treatment of addictions associated problems and conditions and negotiates with other providers the aspects of care related to the patient's addiction. The addiction specialist discusses and offers all clinically indicated psychosocial and neurological therapies to the patients, assisting the patient to collaborate in the decision-making. So the addiction specialist partners with the patient. He not only partners with us, but he partners with the patient to bring about the best care package needed for that patient. The addiction specialist makes certain that appropriate support services are available for patients and their families. I've had addiction specialists say to me, oh, well, this patient did not reveal this to you in their psychosocial, and they didn't reveal it to me until testing was done, but they have hepatitis C. So let's see if we can get a doctor on board that can deal with that. Treatment management. The addiction specialist is the manager and director of the quality of care of all the clinicians and their supervisors. They are the one that manage us and manage our supervisors. The reason they do this is because they are the ones managing the treatment process for the patient. The addiction specialist assures that the treatment plan includes referral to associated collaborative social services. They do read our treatment plans, whether we know it or not. They read our treatment plans and sign off on them. It is their signature that's the first one that's going to get in trouble if our treatment plan or our treatment is off. The addiction specialist meets with the patient to determine clinical progress. Standard 5 is care transitions and care coordination. The addiction specialist takes steps to coordinate care, communicates with other treatment providers when necessary, adjusts the treatment plan when there is a change in the patient's physical or psychological health. The addiction specialist ensures that information shared is with the proper patient confidentiality and releases of information. When the patient is transitioning to another level of care as clinically appropriate, the addiction specialist provides transition through the referral process for that patient. Standard 6 is continuing care management. This is provided when the patient achieves stable sobriety, met treatment goals, and is ready for the sustainable self-focused recovery care. The addiction specialist physician encourages patients to provide and meet with designated care providers who intermittently monitor and assess the patient's maintenance of recovery. The addiction specialist physician or other care providers' assessment for continuing care management can include the following: patient and collateral interview, patient and psychological examination as appropriate, structured rating scales, review of current medications, engagement in recovery activities. I have known several doctors to meet with the patient as part of aftercare and continuing care management. What they do is they meet with the patient and they also meet with the spouse or the family member to see how things are going. Medication-assisted treatment, known as MAT, for opioid use disorder combines counseling and other recovery supports with prescribed medications. These medications help reduce cravings and withdrawal symptoms that come from stopping opioid use. The medications approved for MAT are methadone, buprenorphine, and naltrexone. There are some videos that I have put in this that you can also watch on your own that describe MAT services. Medical interventions. There are two keyway medications that work to help opioid use. Methadone and buprenorphine are long-acting medications that reduce craving and control withdrawal symptoms by satisfying areas of the brain affected by opioid use disorder. This allows people to continue to work and function normally. Naltrexone is another one that blocks the pain-relieving effects of opioids and their ability to induce euphoria. These rewarding aspects of opioid use lead to the desire for more. Research shows that the extended-release injectable form of naltrexone reduces cravings. It helps people remain in treatment longer and helps them abstain from opioid use. We're going to talk a little bit about opioid peptides. There's the mu, the kappa, and the delta. Our brain has opioid peptides, which are released by neurons in the limbic system of our brain. Opioid peptides reduce the body and act in neuromodulators that modify the actions of other neurotransmitters in the central nervous system. By altering the electrical properties of their target neurons, thereby making these neurons more difficult to excite, opioid peptides can influence the release of various neurotransmitters. As a result of this modulation, opioid peptides can, among other functions, induce pain, relief, and euphoria, as well as certain behaviors, including alcohol consumption. So we're going to look a little with opioid peptides here. So we have the mu, which is the brain reward system. This is the mu opioid peptide. Then we have the delta, which is the emotional reasoning peptide. Sorry, the delta is all the way over here. I thought it was in the middle. And then we have the kappa, which is responsible for pain relief. This is the kappa. They're very, very similar, as you can see, these opioid peptides. And the mu, again, is the one for the brain reward system. The delta is for the emotional reasoning peptide, and the kappa is the pain relief peptide. What happens in opioid withdrawal? Opioids are synthetic or a natural drug that have certain unique effects on the brain and body. Opioids relieve pain and give people a sense of well-being or euphoria by changing the body and brain chemistry. The first change many people notice is tolerance or the need for more of a drug to get the desired effect. So in this picture here, we see normal action. Okay, and in this picture here, we see the action of the opioid peptides working on the receptor. We see that these peptides bind to the receptors, and therefore they excite the receptors. And here, they're releasing into the body that excitement. So that's what opioid withdrawal is. This is when the opioid is stimulated, and this is when it's normal or withdrawing, because there is no opiate that is acting in this space to cause the excitement of the opioid peptides. So how does buprenorphine work? Buprenorphine has been around since the 2001, 2002. Buprenorphine is the primary active compound that reduces the patient opioid craving and withdrawal symptoms. It may be used to discourage patients' use of non-prescribed opioids by binding to the mu receptors. And the mu receptors are for pain. The naloxone compound in Suboxone is included to help discourage diversion and misuse. Naloxone has a very limited bioavailability when administered sublingually. However, Suboxone is crushed and injected. The naloxone will precipitate opioid withdrawal. In the absence of an opioid, the agonist has no direct effect. Suboxone or naloxone, buprenorphine naloxone, is a tablet film that is used for the treatment of opioid dependence. It's an opioid antagonist, and it has a 4:1 buprenorphine naloxone ratio. So here we see with buprenorphine prior to use. We see the opiate does some binding here, and we see the excitement going here. This is the euphoria. And we see here that what the buprenorphine does is it binds evenly with these receptors. So the euphoria is very dissimilar to what's happening here prior to use. So actually, with binding to the receptors in a unique and even pattern, the person on Suboxone feels more normal. Methadone, that's been around since the 50s. It was originally derived in a lab in Germany by Dole and Neiswinder. Methadone is a long-acting opioid medication that reduces cravings and withdrawal symptoms. It's usually taken by the mouth in liquid form. However, they do have tablets and methadone pills. Methadone satisfies the area of the brain that opioids act on, calms withdrawal symptoms, and reduces drug cravings. It can block the intense euphoric effects of heroin and other short-acting opioids. Methadone can have a leveling effect with fewer highs and lows. It controls withdrawal symptoms and blocks craving. People who are addicted to opiates tend to stick with it. This allows them to rebuild a life in recovery and avoid the health hazards and problems that come with an illegal drug use. When I was first a clinician, I wasn't even really a clinician. I was just out of college. I worked in a methadone clinic in Maine. And you think, oh, Maine didn't have a heroin problem. Well, yes, they did. They had a big one. So I worked in this methadone clinic, and I worked for a very wonderful doctor, and I had a great clinical supervisor. But I did learn a few things with methadone maintenance. The doctor was very conservative and would not overprescribe the methadone. However, there was another clinic in town that I won't name names, but had patients on 1,200 milligrams of methadone. That clinic was raided by the federal government and the record seized and shut down. But what happens with methadone is Dole and Neiswinder, after they developed it, they started to use it in clinical trials in New York City in Rikers Island. And what they did is prisoners that were addicted to heroin that were coming out of prison, they started to give methadone to as a trial. So they had, I don't know, maybe 50 prisoners. I can't remember the number of prisoners that they had on this trial of methadone use. They administered methadone at 60 milligrams. That was the initial dose of methadone. And what they did is they started them with this methadone. They kept them on the 60 milligrams. And then after they got a job in the community, when they were released, they titrated them down. So it was like the first pre-release program. So within a year, they were supposed to be titrated off this methadone, and they came to live life without using methadone and maintain their job. This was a clinical trial that was done in the early 60s, late 50s, early 60s by Dolan Nicewinder at Rikers Island in New York. So we can see that the highest dose of methadone given to any one of those inmates was 60 milligrams. That was the standardized dose of methadone. Today, most clinics start patients at 60 and titrate up from there. So we've seen over the years that methadone is inducted at a higher level. This is in the clinic setting. If you go to the doctor's office and you take methadone, you don't need 60 milligrams. You might get 10 milligrams if you broke your leg and, you know, it's after you've been having some pain. They might give you 10 milligrams of methadone or 20 at the most, but they're not going to give you 60. Most generalized methadone doses are between 150 and 200 milligrams. That's your general leveling dose for methadone today in the clinics. People that are over 200 milligrams have had a high tolerance, and they've had some effects that result from being on too much methadone. When a person is on too much methadone, they get a nodding effect. Methadone is time released in our body. So it starts working after 4 hours. So what happens is after 4 hours, the methadone starts to work. So that's when we get the nod if the patient is on too much medication. They also get the euphoria. Being a clinician in a methadone clinic, I saw a lot of crazy things. But one of the crazy things I saw was that people would sell their take-homes and use other drugs. So this is something that we have to be aware of when dealing with patients who are dosed. Now, talking a little bit about what naltrexone is. Naltrexone blocks opioids from acting on the brain to induce euphoria and relieve pain. This removes the rewarding aspects of opioid use that create a desire for more. Naltrexone does not help with withdrawal and cannot be started until 7 to 10 days after last opioid use, when withdrawal symptoms have passed. It is available for extended release injectable forms administered every 30 days, or in tablet form taken daily by mouth. Risk of overdose is high when people use large amounts of opiates while taking naltrexone to override the blocking effect. There is also increased risk of overdose if people skip dosages at the end of a dosage cycle or use after a period of taking naltrexone. This is because their tolerance goes up while they are free of taking opioids. Taking amounts that once they tolerated can result in overdose fatality, and they also should avoid drinking while taking naltrexone. Sublocade. Sublocade is new in November of 2017 and FDA approved. A once-monthly buprenorphine injection that delivers a sufficient dose to treat a patient with moderate to severe opioid use disorders. Sublocade is indicated for treatment of moderate to severe opioid use disorder in patients who have initiated treatment with a transmucosal buprenorphine containing product. So they have to be on buprenorphine before they can get Sublocade. Sublocade is It should be used as part of a complete treatment program that includes counseling and psychosocial support. Important safety information is prescription use of this product is limited under the FDA and the Drug Treatment Act. And there's a website here where you can get information on Sublocade. What is opiate intoxication? The person's consciousness is sedated. They could feel drowsy. They could have slurred speech or nodding, or intermittent dozing. They could have memory impairment, mood could be normal to euphoric, and their pupils constrict. Opioid overdose. The person is unconscious with pinpoint pupils. They have slow, shallow respirations, below 10 per minute. Their pulse rate is below 40 per minute. The overdose triad is apnea, coma, pinpoint pupils, or fluid or fixed and dilated pupils. So part of the COWS, we need a nurse or doctor to administer, and we assess the patient's severity of their pulse rate, whether they're sweating or not, whether they're upset, whether they have tremors, how they look, how their skin is. This is something that is very important when we see patients coming into an inpatient treatment setting, or it can be used by a nurse or doctor in a clinical setting. Some clinical practices for the counselor. What is important? We have to recognize the role of being an assistant to the medical staff in the treatment of opioid use disorders. We have to be adept at identifying withdrawal symptoms in our patients, relapse triggers, co-occurring disorders, issues in the family and recovery environment, and some post-acute withdrawal symptoms. In this slide here, we see this is the amygdala, or the emotional center of the brain, and this person in this CT scan or of the brain, the CAT scan of the brain, is this person is high on opiates. So we can see how highlighted the amygdala is and how it's not highlighted in these other areas. Assessment. How do we begin with assessment? We use the CAGE, the DAS, the MAST, the DSM criteria, and the psychosocial to assess our patient in opioid use with opioid use disorders. We discuss current and previous substance use with the patient, how long they've used for, how much they've used for, when did they start using, when did they stop using, were there any periods where they've stopped use entirely or been on addiction maintenance therapy. The length and start of their treatment history. We discuss the pertinent treatment measures that were helpful to them and some that they found not helpful. We discuss with them recommendations for level of care, treatment planning recommendations that we might have, and some treatment planning recommendations that they might have. We discuss the appropriate use of consents and have them sign them, and we talk to them about duty to harm and duty to warn. The patient is scheduled for the initial visit with the doctor. A lot of patients come into treatment and they want to meet with the doctor right away before they meet with you, and they're very antsy in your chair. And what they do is they want to get through the psychosocial quickly, and that's the process where we need patience with our client to tell them that the most thorough history that we can have with them will give the doctor more information on how to treat them better so that they can recover from opioid use. The patient that is sent to the doctor then has some lab work done. The patient meets with the medical provider. The patient is then scheduled for treatment groups and counseling sessions. Pharmacotherapy is used with psychological therapy so that we can treat our patients appropriately. We have to take into effect their biology, their genes, the environment in which they live, the drugs that they've used in the process, how their brain works, and how this all leads to their addiction. Screening is a 5-step process. We identify individuals who are at risk for developing drug or alcohol-related problems. 2, we identify individuals that may have developed drug or alcohol-related problems or addiction. 3, we identify individuals who require further medical or addiction assessment. 4, we diagnose addiction or other substance-related disorders. And 5, we develop recommendations and plans for care, and we assess the biopsychosocial needs of our patients with addiction problems. Now we're going to go a little bit into the stages of change. We're going to start here with pre-contemplation. That's the first stage of change. They're not currently thinking about change. Their ignorance is bliss. They validate lack of readiness, they clarify the decision is theirs, and they encourage reevaluation of their encouraged behavior. I like using, so I'm going to continue to use. Contemplation. They're ambivalent about change. They're just sitting on the fence. They're not considering change within the next month. They validate their lack of readiness. They clarify the decision is still theirs. They encourage evaluation of the pros and cons of behavior change. Well, if I change, this will happen. If I don't change, this will happen. Preparation stage of change. They experience with change and trying to test the waters. They plan to act within the next month. They identify and assist in problem solving, look at obstacles. They identify some social supports, verify the patient has underlying skills for behavior change. They encourage small steps. The action stage of change. This is practicing behavior for the next 3 to 6 months. This is when they actually engage in change. They focus on restructuring cues and social support. We as clinicians bolster their self-efficacy for dealing with obstacles. We help them combat feelings of loss and reiterate the long-term benefits of recovery. Then there's the maintenance stage of change, which is continued commitment to sustaining a new behavior for at least 6 months to 5 years. The plan for follow-up support. We help reinforce internal rewards. We discuss coping with relapse and what that may look like, and we develop a relapse prevention and aftercare plan at this stage. Then there's the relapse stage of change, or recurrence as they call it, and it's the resumption of old behaviors, the fall from grace. We help them evaluate triggers. Why did they use? Releases for motivation and barriers, and plan stronger coping strategies with our patients. The Prochaska and DiClemente stages of change model has been effective in the treatment of people with addictions for years. Well, we look at the stages of change model, and why we look at it is we want our clients to understand what stage of change they are in, and we want to look at some of these techniques over here to help them get ready to prepare for moving to the next stage of change. So some opioid withdrawal symptoms is rhinorrhea, which is runny nose, cramping, diarrhea, anxiety, nausea, high levels of stress, flu-like symptoms, inability to eat, inability to sleep, some skin itching, and some minimal coping skills for extreme emotions. Is a shorter binding drug. We have the onset of withdrawal in 8 to 12 hours and the peak in 36 to 72, and the withdrawal ends in 7 to 10 days. Hydrocodone and methadone. This is the longest binding drug to the receptors. The withdrawal ends in 14 to 21 days. This ends our PowerPoint presentation for tonight. So what I'd like to have you do is kind of study this over, look at the clinical opioid withdrawal scale, look at some of the assessment tools that I provided, and what we'll do is we will resume on Thursday night and go over best practice techniques for treating the opioid client. Have a great week. See you then.